The Johns Hopkins University School of Medicine is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The Johns Hopkins University School of Medicine designates this live activity for a maximum of 0.5 AMA PRA Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in the activity. After attending this activity, the participant will demonstrate the ability to 1. Recognize the impact that substance abuse, violence, and depression have on patient adherence and quality of life in the setting of HIV. 2. Review screening for interpersonal violence, or IPV, substance abuse, and depression in the clinical setting. 3. Discuss appropriate referrals for care, such as social service, psychiatric, and substance abuse specialists when screening is positive. It is the policy of the Johns Hopkins University School of Medicine that the speaker and provider globally disclose conflicts of interest. The Johns Hopkins University School of Medicine, OCME, has established policies in place that will identify and resolve all conflicts of interest prior to this educational activity. Detailed disclosure will be made in the instructional materials. My disclosure at this time is that I have owned stock in Gilead Sciences. This activity is supported by educational grants from Gilead Sciences Incorporated. All activity content and materials have been developed solely by the Johns Hopkins activity directors, planning committee members, and faculty presenters, and are free of influence from Gilead Sciences Incorporated. Women currently account for approximately 23% of people living with HIV and 19% of new HIV infections. Among all women diagnosed with HIV, 61% are African American, 19% white, and 16% Hispanic or Latina. Heterosexual contact accounts for 87% of diagnoses, and injection drug use accounts for 12%. About 87% of women identified with HIV in 2015 had previously tested positive for HIV but were not receiving HIV care. In 2014, approximately 2/3 of women with HIV received medical care, 50% were retained in care, and 48% had a suppressed viral load. In Baltimore City, the figures are 73% retention in care and 45% viral suppression. In our clinic at Johns Hopkins, we have been successful in achieving viral load suppression in 89% of women. Epidemiology, however, shows that African American women with HIV are less likely to achieve viral suppression than white women with HIV, 42% versus 47%. Viral load suppression is incredibly important in the management of HIV. Maximal and durable viral suppression prevents or delays selection of drug resistance, preserves or improves CD4 cell count, reduces HIV-associated morbidity, and prolongs duration and quality of survival, and prevents HIV transmission. HRSA and CDC state that people living with HIV and AIDS who take HIV meds daily as prescribed and who achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV-negative partner. And this is often referred to as U equals U, undetectable equals untransmissible. With the HIV monitoring report, there is evidence that HIV viral suppression is increasing, And you can see from this slide from 2010 to 2015 that the proportion of persons with diagnosed HIV who are virally suppressed increased from 46% to almost 60%. In 2015, 86% of persons with HIV knew their HIV status, and 76% of newly diagnosed individuals with HIV were linked to medical care. This data includes information from 40 jurisdictions. This slide portrays data from 2014, 2015, and 2016 regarding viral suppression among individuals with HIV who are in care by different demographics. And what I think is important to recognize is that there are certain categories of individuals with HIV who still lag behind in terms of viral suppression. You can see that that's particularly true in adolescents, age 13 to 19, in Black or African American individuals with HIV, and Hispanic individuals who lag behind white individuals with HIV. You can also see that transgender persons have lower rates of viral suppression than others. In general, women are slightly behind men in terms of overall levels of viral suppression. This data portrays viral suppression among women served by the Ryan-wide HIV/AIDS program from 2016 in the U.S. and U.S. territories. Women overall had a viral load suppression of about 84%. But again, that varied dramatically by age, as well as among those who have perinatal infection and those with unstable housing who had lower rates of viral suppression. The concept of SAVA, standing for Substance Abuse, Violence, and HIV/AIDS, was conceptualized in 1994 as a set of closely intertwined and mutually enhancing epidemics that are fueled and sustained by social and economic inequities. HIV, substance abuse, and violence each contribute independently to the collective health burden on women, but they also act synergistically to negatively affect HIV outcomes. And so the co-occurrence of these factors is termed the SAVA syndemic. We also believe that an important part of this syndemic is depression, and we will be discussing that in this educational activity. Depression is independently associated with each element of SAVA. The syndemic effect of living with all three SAVA factors is associated with an increased risk of depression among women. In one study of 445 urban women who had experienced all three SAVA factors, they were 6.8 times more likely than women with no SAVA factors to have depressive symptoms. Depression is also associated with lower adherence and lower quality of life. Substance abuse is a national public health crisis. In 2015, 22 million Americans needed substance use treatment. Only 2.3 million of these actually received treatment. In 2015, 27.1 million Americans aged 12 or older were current illicit drug users. And drug overdose is the #1 cause of injury-related death in the U.S. currently. This slide demonstrates the drugs involved in U.S. overdose deaths from 2000 to 2016. What is very apparent from this slide is an increase over time in the use of both natural and synthetic or semi-synthetic opioids, with a dramatic increase from about 2013 to 2016 of synthetic opioids other than methadone involved in these overdose deaths. This slide represents some general statistics concerning IPV and depression. 31% of U.S. women will experience physical violence by an intimate partner during their lifetimes. 47% will experience psychological aggression. 50 to 60% of women on public assistance have been victims of domestic violence as adults. The costs of IPV exceed $5.8 billion each year. And approximately 7% of U.S. adults have had at least one major depressive episode in the past year, and the lifetime prevalence is much higher. There are higher rates of trauma-related mental health conditions among IPV survivors, with nearly 3 times the risk for developing major depressive disorder or PTSD. Women with recent history of experiencing IPV have nearly 6 times the risk of problematic alcohol use. The prevalence rates of substance abuse or abuse among IPV survivors varies in different studies from 18% to as high as 72%. And the prevalence rates of IPV among people who are using illicit substances or alcohol vary from 31% to 90%. There are various interrelationships of IPV, depression, and substance abuse in the setting of HIV in women. Physical IPV alone increases the risk for HIV in women by 28 to 52%. Sexual IPV is reported more often as an independent risk factor than any other form of IPV. Women in relationships with violence have approximately a 4-fold greater risk of contracting STIs than women in relationships without violence. Substance abuse has long been recognized as a major risk factor for HIV transmission. Injection drug use is the transmission category for 7 to 28% of women with newly diagnosed HIV, but non-injection drug use and alcohol use, misuse, increase the risk through impaired judgment and disinhibition as well. Depression independently is associated with increased risk behavior for HIV in women with alcohol misuse. This graphic demonstrates the relationship between IPV and HIV, with multiple factors increasing the exposure to interpersonal violence, such as early sexual debut, higher number of partners, propensity for current partners, and partners with a propensity for concurrency. All of these may feed into an increased risk of exposure to IPV. IPV then often is associated with reduced condom use, higher relationship dissolution, lower rates of entry into marriage, an increased number of secondary partners, and lower antiretroviral therapy effectiveness. And these, again, downstream increase HIV risk for women and for men. Women with HIV experience more frequent and more severe IPV than HIV-negative women. In one study, 55.3% of HIV-positive women experienced IPV, which is greater than 2-fold higher than the national rate. 1/3 of the 1.2 million people living with HIV in the U.S. drink alcohol in unhealthy amounts or use illicit drugs. And depression is the most common psychiatric comorbidity among persons living with HIV. It affects 30 to 40% of infected adults. It is 3-fold higher than among the general population. Women with HIV are 2-fold more likely than men with HIV to have depression. And approximately 50% of those with depression go unrecognized, and 50% of those recognized are untreated. Substance use disorders are common in persons living with HIV. This study reported in AIDS Behavior in 2017, including over 10,000 individuals living with HIV, looked at the breakdown of substance use disorders. 48% had any substance use disorder. 19% involved alcohol, 4% opioids, 11% cocaine, 31% marijuana, and 13% methamphetamines. Trauma or past history of trauma also includes post-traumatic stress disorder, and PTSD and HIV commonly go together. There's a 10 to 20% prevalence of PTSD in the general population, but the prevalence and incidence of PTSD is higher in HIV-positive patients. The lifetime risk of PTSD in the setting of HIV is about 54%. PTSD related to HIV is about 40%. And women with HIV are about 2 times more likely to have PTSD than men. Patients with PTSD are 2 to 3-fold more likely to have substance use disorders as well. This is a study involving a meta-analysis of psychological trauma and PTSD in HIV-positive women, published in AIDS Behavior in 2012. And this looks at prevalence rates of traumatic events and PTSD in HIV-positive women. If you look at the third column for the prevalence involving various traumatic events, you see that all of these numbers are quite high. Intimate partner violence prevalence was 55.3%. Adult sexual abuse, 35.2%. Adult physical abuse, over 50%. Childhood sexual abuse was high at 39.3%. Childhood physical abuse, slightly higher at 42.7%. Or abuse unspecified in childhood, close to 60%. And then if you look at the bottom 3 numbers, for lifetime sexual abuse, 61%, lifetime physical abuse, 72%, and lifetime abuse unspecified, 71.6%. You can see that this is truly a critical problem in the setting of HIV, and one that impacts every part of HIV care. This is a study examining the relationship between various factors. It's a study of 563 HIV-positive women of color, 67% Black and 26% Hispanic or Latina, at 9 different sites. And the study examined the relationship of 5 psychosocial factors associated with SAVA, including poor mental health, substance use, binge drinking, IPV, and sexual risk-taking. And you can see that the odds ratios are for poor mental health, for instance, and substance abuse is significantly increased at 1.4, binge drinking 1.6, IPV 1.94. You can look at all of these and see that there is a significant correlation and a statistically significant correlation relationship with several of these factors. As the number of psychosocial problems increased in the same study, the likelihood of viral suppression decreased. The additive effect plateaued with greater than or equal to 3 psychosocial problems, and this suggests a threshold beyond which an increasing proportion of women have poorer clinical outcomes. Depression in persons living with HIV is associated with negative health behaviors and outcomes. It has been associated with reduced antiretroviral therapy adherence, missed HIV primary care appointments, reduced viral suppression, and higher rates of AIDS-related morbidity and mortality. Women with a history of violence are certainly less likely to have viral suppression. In one study, 76.4% versus 93.3% in those without a history of violence. Experiencing physical and other types of IPV increases the likelihood of not getting tested for HIV, as well as not accessing or staying in care, and poor ARV medication adherence among women who use drugs. Childhood sexual abuse is a strong risk factor for substance abuse, particularly injection drug use. Engaging in risky sex and failing to engage in HIV care and medication adherence. Several studies have shown an association between specific substance use and detectable HIV viral load. There is a relationship of contextual, psychological, and environmental factors with adherence to ART. Depression and adherence self-efficacy were significant predictors of adherence, and fewer depression symptoms predict higher self-reported ARV adherence. This study represents data on alcohol and illicit drug use and viral suppression. It was a cross-sectional study from 2012 to 2014 of HIV-positive individuals on ART, but who also had a current substance use disorder. The number of drug dependence criteria was associated with less than 90% ART adherence and lack of viral suppression. The past 30 days specific substance use or heavy drinking days, which was greater than or equal to 4 drinks per day in women, greater than or equal to 5 drinks per day in men, was associated with decreased adherence, as well as the severity of the drug or alcohol dependence in the preceding 12 months. Nevertheless, approximately 75% of the substance-using cohort receiving ART were able to achieve virologic control. This study suggested that the criteria for drug dependence rather than the specific substance used was associated with a detectable viral load or lack of total virologic suppression. This study, reported in JADES in 2011 by Frederick et al., suggested that opiate substitution therapy, including buprenorphine, naloxone, especially over time, were associated with improved HIV clinical outcomes, including the percentage of individuals who were on antiretroviral therapy and the percentage of those who achieved viral load suppression. There are also studies that show that treatment for depression can improve outcomes among persons living with HIV. Treatment has been associated with reduced depressive symptoms, as well as improved ART adherence and viral suppression. Drug use is independently associated with poor outcomes along the depression treatment cascade. Current drug users are the most likely to need depression treatment, but the least likely to receive treatment or to have remission of their depression. This study, reported in JADES in 2018, suggests that treatment with SSRIs improves adherence to antiretroviral therapy. And in the same study, treatment with SSRIs improves HIV outcomes, including viral load suppression and improvement in CD4 cell count. So we are in a unique position to identify, intervene, and potentially modify these conditions with an improvement in HIV outcomes. However, clinicians treating women with HIV may not be sufficiently aware of the interaction of these factors, substance abuse, IPV, and depression. At a large urban academic center, 50% of clinicians rarely or never screen women with HIV for substance abuse. 83% of clinicians rarely or never screen women with HIV for violence. So women affected by SAVA remain invisible and at risk for achieving suboptimal outcomes. Thank you for listening, and please stay tuned for part 2.